This is a case of a 75-year-old lady who had a domestic fall and had a left intertrochanteric fracture. As you can see, the fracture line is over here. This is a classical case of an intertrochanteric fracture. The patient is grossly osteoporotic. As you can see, this is a type C canal. We are going to reduce it on a fracture table and do a proximal femoral nailing. Actually, trochanteric femoral nailing, 18 centimeter nail we are going to use. Today we are going to operate a case of left IT fracture, intertrochanteric fracture. As I previously told and shown in the X-ray, this is our position, optimal position. I make it a point to break from the mid-abdomen to the lower leg, so I can free space and take the nail. We have covered the private parts just for video sakes. Now the reduction maneuver in IT fracture is very important. The proximal fragment is always flexed, abducted and externally rotated. So the initial traction I apply with the distal fragment in flexion, abduction and external rotation. Then I adduct and internally rotate. On the AP view, this is the reduction which you should obtain. The lateral reduction is very important in intertrochanteric fracture. So you just take a look at the lateral X-ray as well. This is the lateral reduction. The two most important factors in anatomically and perfectly reducing intertrochanteric fracture is first, the medial continuity line. The Shenton's arc should be maintained. See how perfectly the medial arch is maintained. And in the lateral view, the most important thing is the anterior cortical line has to be maintained. Sometimes there will be a posterior sag. We'll make a separate video for it later on. But for all the young orthopedic surgeons watching out there, these are the two lines which you should maintain. Once this is maintained, it makes your life a hell lot easier. Three things. This is our final position. The right lower limb is kept in a lithotomy position so that it doesn't come in the way. It is abducted and kept in a lithotomy position. This is the position of our C-arm. We can get a good AP and lateral view through this. This is our final draping so that no unsterile part is touched. The sterilization procedure for this case is initial scrubbing with betadine and beta-scrub, then second scrubbing with spirit, and after the draping, the final cleaning with sterilium again. Prophylactic antibiotic is given at least 60 minutes prior to incision. Incision need not be long. It is hardly a 4 to 5 centimeter incision. But as you see in the C-arm, we make it a point to mark it on the C-arm and check it. It should be in line with the femoral canal, so you don't have to struggle to go anteriorly or posteriorly and can get pitch perfect entry. Entry is the most important point in any femoral nail, be it an interlock nail or a proximal femoral nail or a trochanteric femoral nail. Entry is the most important. As you can see, we have made the incision. Skin and subcutaneous tissue have been incised, and then we have added the self-retaining retractor. Now we will divide the tensor fascia lata, if you can see, and gain entry into the gluteal muscles. To the skin and subcutaneous tissue, we have exposed the TFL. Now we will incise the TFL. Be as gentle as possible. We will incise it with a 15 number blade. Just be gentle. We do not want to cause any traumatic injury to the underlying gluteal muscles. Gluteal muscles should be dissected blunt with the help of an artery forceps. Now we have just opened the TFL. We don't need to make a very huge incision. It should be small. Now we'll reposition our self-retaining deep to the TFL. As you can see, we have divided the facial layer. These are the gluteal muscles. We'll gain entry into the gluteal muscles with the blunt artery forceps, and just expand it to create an opening. And I'll just put my finger inside and palpate the tip of the greater trochanter. The gluteal muscle should be divided as atraumatic as possible. Entry point, as I said, is the most important. For trochanteric femoral nails, the entry should be this. This is the slope of the greater trochanter. This is the depth. This is the lateral border. This is the medial border. Medial border of the greater trochanteric is the ideal entry point for trochanteric entry portals. This is known as medial trochanteric entry portal, MTET. Okay, this is very important. This is the view on AP. On lateral, I'll show you what should be the ideal entry point. I'm just starting to make the entry. I won't go deep. Sure? Sure? This is the entry on AP, but I won't go further deep till I'm sure of my entry in the lateral view. This is the entry on the lateral view. Mark it. The entry should be the junction of the anterior 2/3 and posterior 1/3. That will give you proper access to the medullary canal without causing cortical breach in the neck of the femur or posterior blowout. So we have reconfirmed the entry on both AP and lateral view and advanced our owl distally up to the lesser border of the lesser trochanter, inferior border of the lesser trochanter, so as to open the medullary canal. Now the trick is to place your finger on the hole created and use that finger as a landmark for entry of the guide wire. The AP and lateral view. The most important thing now is reaming. You cannot just directly put in the nail. This is a standard trochanteric femoral nail. This is the proximal portion of the nail. This is the distal portion of the nail. The proximal portion of the nail has a standard diameter. It is around 15 to 16 mm, which is same for all the nails of all the sizes. Only the distal diameter differs, whether it's 11, 12, 9, 10, only the distal diameter differs. So very common mistake which newcomers make is they calculate, okay, we have to do a 11 mm ream and we have 11 mm nail. So they ream up to 12 mm and try to put a 11 mm nail. But this proximal diameter is around 15 to 16 mm for standard nails. So for that, you have to initially ream the proximal end by this reamer. The diameter of this proximal entry reamer is 16 to 17 mm in standard PFN sets. You progressively ream the femur and use this solar protection sleeve to prevent damage to the soft tissues. You start from the lowest possible 8, and when you hear the cortical chatter, you stop. Rest you risk causing a retrogenic femur fracture. In femur nailing, there is a big risk of fat embolism, pulmonary embolism. So the measures I take to prevent or minimize embolism is, one, before reaming, after the guide wire goes in, I give 2 IV doses of steroids, hydrocortisone 100 mg and dexamethasone 8 mg. Oxygen is kept at around 6 liters per minute and IV fluids is kept at 120 ml per hour. We always monitor the urine output so that your patient doesn't have a fluid overload. Also, in our setup, we have a practice of giving DVT prophylaxis since the time patient is admitted. Usually, we give injection Flexion 0.4 ml pre-op, and we withhold it 12 hours after the surgery and restart it 12 hours after the surgery. This is your entry of the nail. Shoot. 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 So, for a dual screw proximal femur neck system, usually the inferior screw, which is the load bearing screw, which contributes to the stability. In the AP view, I try to get it as inferior as possible, kissing the calcar. And in the lateral view, I try to get it slightly posterior to the center, which is the strongest portion of the femoral head. And the superior guide wire, which is guide wire for the derotation screw, its job is only to prevent the rotation. It doesn't contribute to the load bearing capacity, load sharing capacity. It doesn't contribute to the stability, but its job is to prevent the rotation of the fragments. So that wire should be parallel to this wire in both AP view and the lateral view. Now, this is what I call the pitch perfect placement of guide wires. In the AP view on the right, you can see both wires going parallel to each other superiorly. And in the lateral view, you can only see one guide wire. You don't see one here and one there. It should be dead straight, one below the other. The sizing of the screws. The sizing of the screws depends on two things. One, it should be about 10 mm from the subchondral bone. It should have very good hold. Even if you want to go deep and less gap between the subchondral bone and the screw head, it's okay, but it should have a good hold. Second, it also depends on the amount of distraction you have at the fracture site. In our case, it's not much distraction, so less amount of traction needs to be released. So right now we have got lengths of 95 mm for the cortical screw and 85 mm for the derotation screw. So we will take those lengths because less amount of traction will be released, and the lady is very osteoporotic, so we need to go deep underneath the subchondral bone. Big debate which screw should be put first. There are theories and debates for and against, but personally what has given me good results over more than 1,000 hip fracture cases is putting the derotation screw first, which provides good rotational stability to the proximal fragment in case of IT and comminuted neck intertrochanteric fractures. And I put primary stability screw, the inferior screw, after I put the derotation screw. There will be a controversy. Theoretically, it is always advised that the tip of the inferior screw, tip of the superior screw, and tip of the nail should lie in one horizontal line together. But it's not, it should be horses for courses. If you try to align it and don't have hold of the screws, eventually the screws will back out. So the thing is, especially in osteoporotic females, to have good subchondral hold. The superior screw, when I tried to keeping with the alignment, it had no hold over here. To get good hold, I have put it almost 10 mm inferior to the subchondral bone, and the superior screw, I have kept the gap of about 5 mm. Distally, I am going to do both static and dynamic locking, so as to do not having a side effect. And I will delay the weight bearing of this patient to up to 6 weeks. After which gradually we'll start weight bearing and full weight bearing up to 10 weeks. And this is what we call a picture perfect X-ray. This patient, God willing, will have a excellent outcome, and she can be full weight bearing without support in about 2 months time. Now is the start of the closure thing. We'll give a wash of around 3 liters to prevent any perioperative chances of infection, and then take stitches. We'll start from the deepmost layer of TFL, then subacute, and then skin, which my assistant, Brother Sachin, will take. And we are operating here in this beautiful OT at Yeshwadhara Super Speciality Hospital. And as the name suggests, it is a super speciality hospital with highly qualified surgeons, and we do an excellent job day in, day out to give the patient the best possible outcome.